I now invite our urology veteran, who is the founder of Gibbs, Chairman Gibbs, senior consultant and advisor, urology and robotic surgery, Indraprastha Apollo Hospital, Dr. Rajesh Taneja. Welcome, sir. We are looking forward to hear from you from the urology perspective of bladder pain.
Thank you very much, Dr. Meera, and thank you, the Trichy Gynae and Urology clubs, for hosting this meeting. And it's been a real pleasure to hear Dr. Ramani Devi, and she was speaking more like a urologist than a gynecologist when she was talking about the urethral stenting and the indications of ureteroneal cystostomy and when not to resort to medical management and the surgery is indicated. I think that
Sir,
was.
shall I add one more thing?
Yes.
I was working with Professor Raja Mageshwari for 2 years.
Yes.
That has given me the confidence of at least doing some work in cystoscopy and all those things, sir.
Yeah. So
to quote Dr. Ramani Devi ma'am in her own words, if she was in Chennai or in one of the metros, she would be a urogynecologist, of course, the leading one, which she's already now. But this is to quote from her own words.
So it was really nice. And I know we are here for a particular mission for the next 10 minutes. And I'm going to talk about cystoscopy in a female patient suspected to be a case of bladder pain syndrome or interstitial cystitis. So, this is a typical Hunner's lesion. I bring this picture always there. It is the most important thing is that the rest of the bladder is normal, and there is a grayish white zone in the center with parallel radiating capillaries, and it is typically a star-shaped lesion. So with this lesion, we go to the presentations. So what are the indications of cystoscopy in a female patient? There could be diagnostic indications or therapeutic indications. Diagnostic, we know as urologists as a part of workup of hematuria, unexplained urinary symptoms, obstructive urinary symptoms with significant residual urine, incontinence of uncertain etiology, and planning of complex anti-incontinence procedures whenever you're doing that, and of course, the bladder pain syndrome. Now, it could turn to be a therapeutic cystoscopy if you are resecting a bladder tumor, or if you are doing a hydrodistension for a bladder pain syndrome, or if you are ablating a Hunner's lesion, or some other procedure for bladder outlet obstruction. So whatever be, my job here, I think, is today's time when Meera gave me this topic is actually role of cystoscopy in BPS-IC. So when we talk of when to do cystoscopy in a suspected case of bladder pain syndrome, if we go back to the ESIC guidelines, the European Society guidelines, which were given and taken up by the European Urology Association. And they said that it is an essential part of workup of a bladder pain syndrome. That means you have to do a cystoscopy, you must do a biopsy, and then there is a method of describing the findings and classifying the interstitial cystitis or bladder pain syndrome as it was mentioned then. However, if you go to the American guidelines, they talked about the fact that cystoscopy may not be essential to start treatment in a case of suspected BPS-IC. The reason being, they thought that, when the patient comes, the history and the non-invasive investigations are so much clear. So if the urine is silent, ultrasound they would not do. If the urine is silent, patient has typical symptoms, then of course you can start treatment without waiting for a cystoscopy. So that is where the indication for cystoscopy in BPS-IC was divided. And we at Gibbs started looking at these things critically, and we realized that in India, at least, we should have cystoscopy as essential part of diagnosis before planning treatment. It is very essential, not only morally and ethically, but legally, to exclude pathologies like proliferative cystitis, which is cystitis cystica and cystitis glandularis, carcinoma in bladder, and tuberculosis. All these things we have seen over the period of years that the patients have been treated as interstitial cystitis or bladder pain syndrome. And for the want of a cystoscopy, they have missed the important and progressive and potentially life-threatening conditions. So I think we would stick on to our indications that if you think there's a patient who has bladder pain syndrome or interstitial cystitis, you should not hesitate to do a cystoscopy before labeling the diagnosis. So another thing, when should a cystoscopy be done in general anesthesia or local anesthesia? So I see so many patients who have been seen by another urology colleague somewhere else, and the cystoscopy has been done under local anesthesia. And many times what happens is the patient has a lot of pain symptoms, the urine routine is silent, the ultrasound is silent, and then somebody says you go to a urologist, the urologist says, okay, I will do a cystoscopy. He does a cystoscopy under local anesthesia. The patient is struggling, and as the patient is struggling, sorry, because the patient is having pain, so patient is not relaxing, and the surgeon gets frustrated. You must understand, bladder pain syndrome means when the bladder is filling, there is pain, and you're trying to fill the bladder, and the anesthesia that you are providing is only into the urethra and the trigone. So our problem is that this patient, who has been labeled as perhaps functional because urine routine is silent, ultrasound is silent, the urologist does a cystoscopy, he's frustrated because he cannot distend the bladder, and he comes out and says the bladder is normal. So cystoscopy under local anesthesia is not advisable at all. We should have some form of an effective anesthesia for cystoscopy. This also gives us the advantage of some therapeutic procedure. For example, you come across a small bladder or bladder with signs or stigmata of inflammation, like uh, petechial hemorrhages or glomerulations, or a small capacity bladder or edematous bladder, then you have the advantage of distending it if you are doing it under general anesthesia or spinal anesthesia. So if you are doing it under local anesthesia, then you have to post the patient again under general anesthesia, which is not a good thing. I know there are a lot of papers which talk about cystoscopy under local anesthesia. I'm sure it is possible, but the fact is that in whatever patients that I have seen, another problem that occurs is that they come to you, somebody has done a cystoscopy under local anesthesia, reported normal, and you tell them, I'm going to do a cystoscopy. They run away. They say, no, I will do everything, but not the cystoscopy. They are so mentally traumatized by cystoscopy under local anesthesia that they would not allow you to do a cystoscopy. Then very word of cystoscopy is like a torture for them. So I think we should all make it a point to make the patient comfortable, so that while you are doing a cystoscopy, you are equally comfortable and you take time to make observation and make a diagnosis, and of course do a therapeutic procedure like hydrodistension or ablation of Hunner's lesion. So I talked about Hunner's lesion. It is described as a circumscribed reddened mucosal area. It is circumscribed. It's very important. It's a very well circumscribed. Small vessels radiating towards the center with a fibrin deposit like this. Why I'm showing this Hunner's lesion? I'm showing so many times because, when I look at the literature, there are series of papers on bladder pain syndrome and interstitial cystitis, where the occurrence of Hunner's lesion has been seen as less than 10% in one series to more than 50% in another series. So what is the problem? The problem is that your eyes will see what your mind knows. So it is very important that when you're going in for a cystoscopy, your mind should know what you want to see. And unless your mind knows, your eyes will miss it. And that is exactly the reason why I insist on describing this in this manner. Once you see a Hunner's lesion, you should resect it preferably. Otherwise, electroablation with a ball electrode, like most urologists do with a coagulating ball electrode, that is good enough. There could be ablation of the Hunner's lesion with Nd:YAG laser, holmium laser, and in American groups, what they're doing is they're injecting intralesional triamcinolone, which is a steroid. So which means that Hunner's lesion is considered as inflammation, And injection of steroid in the submucosal area of the Hunner's lesion causes reduction in the inflammation, thus reducing the pain and the symptoms of which are being attributable to Hunner's lesion. So what we propose at Gibbs is that it should be done under general anesthesia. We use a rigid cystoscope, 20 French sheath with a 4 oblique telescope, 30%, and glycine. Or if you're using a bipolar cautery, you can use normal saline, but glycine is what is easily available in most of the urology theaters. Irrigant has to be adjusted to the just enough so that the interior of the bladder is inspected undisturbed, which means that when you start putting the scope, you enter the bladder should be almost 100-150 ml, and you stop irrigation. Because if you continue irrigation, you're going to distend and crack the bladder, and there may be some bleeding that starts. And if the bleeding starts, you get upset because you can't see anything. So you must visualize the interior of the bladder before the bladder realizes that you are there. So you make all the notings. You can then, after you have made notings, for example, for some kind of scars, some kind of lesions, some kind of Hunner's lesions, and then you decide, okay, I'm going to come back and take biopsy from these lesions. So you would make sure to identify where all you want to have the biopsy from. Then you distend the bladder with a drip chamber method. So this is what was described by the president of ESIC, Norling. So he also described it. So what we do is we attach the IV set with a drip chamber, and we keep the bag, the chamber, the reservoir of the glycine at 80 centimeters from the pubic symphysis. So that is what we do, and we allow the water to drip, the irrigant to drip into the bladder. And while the bladder is being distended with this manner, we look for the mucosal cracks. And if there is a Hunner's lesion, you can see it nicely getting stretched and cracked. And that is when you will know, okay, there is enough. So what happens at 80 centimeters, if you are using a drip chamber, suddenly you will realize as the pressure of the bladder is reached within 80 centimeters of water, there would be no flow. So that is when you will know, okay, the distension is at its peak. You wait for 2 minutes, and then you also then, because that is the time when the irrigant is not flowing through the drip chamber, and that is the time you wait for 2 minutes, and then you deflate and measure the quantity of irrigant that comes out after 2 minutes. So this is the measure of the bladder capacity under general anesthesia. So then you take a biopsy with a cold cup forceps, and we introduce the continuous irrigation resectoscope sheath, which is 26 French. We can ablate the Hunner's lesion with either electrode, or we can resect it. After that, we put a 3-way Foley catheter for overnight and connect the irrigation at 80 drops per minute. So I will show you a typical cystoscope. So when you enter the bladder, at this moment, we have stopped the irrigation. You can see a Hunner's lesion there. The most important thing is that the rest of the bladder, apart from the Hunner lesions, so this patient has multiple Hunner's lesions. So rest of the bladder is absolutely clean, uninflamed. And these Hunner's lesions could be contiguous. They can be connected with each other. And this is the time when we are distending. You see hydrodistension is in progress. You can see that the Hunner's lesion, the center of the Hunner's lesion is almost stretched and ischemic. It is the same red pale Hunner's lesion, pinkish capillaries that you had seen. And now we are deflating the bladder. If you see, when you deflate, there are petechial hemorrhages, but they are coming only from the lesions. The rest of the bladder is not oozing or not bleeding. So we know this is how a typical Hunner's lesion would behave during the cystoscopy. So what I do typically is to use a roller ball electrode to cause ablation. So this causes thermal injury to the nerve endings. And since interstitial cystitis or bladder pain syndrome, it is a neuropathic inflammation. So it is the pain that causes inflammation. In most of the situations, it is the inflammation that causes pain. But in this particular situation, it is the pain that causes inflammation. So when we are doing this process, we are burning the C fibers, and then we are taking away the pain and also the concomitant neuropathic inflammation. And that is how the pain reduces in these patients. And the pain, inflammation, pain cycle is cut. So when we do this procedure, you will be surprised that at the end of this procedure, when the patient wakes up, the pain is instantly gone. The pain is instantly gone, disappeared. And that is the advantage, and that is the therapeutic endpoints that you can reach. And when the patient wakes up, there is hardly any pain. So that having done, what we do here is we place the catheter, and the next day morning, what I do, I put in the steroid cocktail, which contains hydrocortisone and heparin, and this was published in 2007 in the Scandinavian Journal of Urology and Nephrology. And this steroid cocktail is put into the bladder, and this is removed. And then the patient is discharged. And I generally ask them to come back for 5 more weekly installations of the solution in 40 ml of normal saline. And this has been published in 2007, but this has been doing very well in my practice, and I will recommend this to anyone who is treating these patients in such a manner. Thank you very much. I hope I have not overshot the time. And if there are any questions, I'll be very happy to answer.
Really excellent talk, Dr. Taneja. As always, brilliant pictures and video.
Thank you. Thank you.
And you are authority on it. And I request everyone to become member of GIBS with Dr. Taneja. He's doing so much. He's doing more for our women colleagues than any of our gynae colleagues, actually, especially suffering from bladder pain syndrome. Thank you, sir.
Dr. Taneja, just a thought. It's just a random thought. You said one of the options used by people in USA for HL is injection of triamcinolone intralesionally.
That's right.
Now, any experience with that? And would that be a better option, considering that if, God forbid, the patient's phenotype is towards progressive disease, the kind of cautery that we use might sort of add insult to the injury?
Yeah. So, Dr. Atulcha, that's a very good thought. So, I have a dedicated lecture on how to handle Hunner's lesions, and one of the slides, I have references where this question has been asked, that if you repeatedly do ablation of Hunner's lesions, will it cause reduction in bladder capacity? The answer is no. So there have been studies, they have been documented, where they say repeated ablations of Hunner's lesions with either electroablation or transurethral resection does not cause reduction in the bladder capacity. And other than that, the advantage of electrocautery is that when you are using triamcinolone, you are depending upon a steroid to reduce inflammation, but you are doing nothing for the C fibers. So with this technique, when you burn the C fibers, the pain drops immediately. The pain score immediately drops. And that is how it works very well. And that fear of reducing bladder capacity due to repeated such procedures is really found to be unfounded.